Okay. Welcome to today's webinar. This is a critical conversation. It's our third critical conversation that's HOPA has hosted. It's entitled Improving Access to Oncology Drug Repository Programs. My name is Ryan Beecher. I'm an ambulatory clinical specialist at the UC Davis Comprehensive Cancer Center. I'm also a professor in the School of Medicine and a professor at UCSF, the School of Pharmacy. I'm honored to serve as your moderator for this important discussion. This is a 1-hour non-CE webinar where we'll explore how oncology drug repositories programs, help to improve access to life-saving treatments, reduce waste, and address real-world challenges in cancer delivery. So a little bit about the schedule. We're all going some opening remarks. We will do some panel presentations, and the panelists, I'll introduce them in a minute. They'll have 5 minutes each. We'll have a moderator-led, that's me, panel discussion that will occur over 15 to 20 minutes, and then we'll allow Q&A to close us out. So these are the objectives. This is, what I would hope for the attendees to get out of this presentation. Describe the purpose of oncology drug repository programs, explore how these programs will improve patient access, discover real-world insights from 4 unique program models, and learn some practical ways to navigate the challenges and maximize the impact. And then, any way that we can get involved as oncology pharmacists to in this work. We are joined by some outstanding leaders, and I would say, as I was preparing for this webinar, I intentionally chose not to learn too much about these individuals on the line because I'm so excited. We have some fantastic speakers, and this is a topic that's near and dear to my heart. I think it should be on the tops of our oncology pharmacists as a whole, because it's really important work that these groups are doing. So I will introduce them one by one, and they'll have an opportunity, as I mentioned at the top, to go into more detail. George Wang is the co-founder of Supporting Initiatives to Redistribute Unused Medications or Medicine, and they go by the byline serum, and he's been on one of these webinars before. So his role is to partner with hospitals and pharmacies and manufacturers to contribute towards this work, and we liked what he had to say so much we invited him back. So clearly you made an impression on the group during the last clinical conversation. So thanks, George, for being here. Siobhan Norman, who is one of the co-founders of YesRx, is a 501c3 organization that is it's a statewide cancer drug repository network. So welcome, Siobhan. John Michael Rossman is the CEO of SafeNetRx, and that's a nonprofit pioneering this work in charitable medication redistribution. And then Dr. Julie Kennerly Shaw, who is the Senior Director of Cancer Pharmacy Services at Ohio State University. And any of us that were in attendance at the most recent HOPA annual conference, we really appreciated your group's presentation on this work. And I think that's what turned my head and say, yeah, we need to be doing more of this at UC Davis at our institution. So thank you for our panelists for being here. Before we get started, oh yeah, sorry, I forgot to advance the slides. Some housekeeping notes. So we encourage audience participation for the Q&A portion of the program. If you look at the bottom of your screen, you should see this Q&A button. So submit your questions at any time. We'll address the questions at the end. If you like a question or you see a similar question to yours, you have the option to upvote it, and we will prioritize those in the questions at the end. The chat function is also enabled, so we encourage you to use the chat. Just keep in mind that the panelists may not see everything posted in the chat, so if you have a specific question for them, please put it in the Q&A box. Okay, So we'll start with a few audience polling questions to help set the stage for today's discussion, and after that, each panelist will share a brief overview of their programs, followed by a panel discussion and a Q&A. So with that, why don't we pull up the panel questions, polling questions? Okay. So this question is, how familiar are you with oncology, drug repository, and donation programs? Choose one. Do I get the option to pick? No, I do not. I would choose somewhat familiar. We'll leave it on the screen for a couple more seconds. All right. Question 2. Oh, sorry. Yeah, so similar. So somewhat familiar was the majority of the case, and sorry, heard of them, but not sure how they work. So okay, so this will be informational for the majority of our audience. Question 2. All right. Does your institution currently participate in or operate a drug repository program? And you can, I won't read the verbose answers. All right. The overwhelming majority of your institutions do not currently participate in cancer repository drug programs. So even more relevant. And the last question is, I think we have 3 questions. Why are you interested in repository programs? I would choose all, 1, 3, and 4, but you can only pick one. Okay. So I want to start my own repository program, and or I'm hoping to collaborate with others. So this will be highly relevant. Okay. Oh, hang on. Okay. So with that, let's dive right in. And so Siobhan, tell us about YesRx.
Sure thing. Thanks, Ryan. So YesRx is a female-founded and led nonprofit organization working to remove barriers to cancer medication access for vulnerable and underserved patients in communities while eliminating cancer medication waste. Like Ryan said, my name is Siobhan Norman. I have 2 co-founders who are pharmacists, Emily Mackler, who serves as the YesRx Chief Medical Officer, and Farah Jalul Risk, who is the Chief Pharmacy Officer for the Michigan Pharmacists Association. Just want to quickly thank HOPA for creating this space for this critical conversation and for inviting YesRx to participate. You can move to the next slide, Ryan. So our state enacted the Michigan Cancer Drug Repository Program, we call it CDR for short, in 2006. And 15 years later, in a community oncology practice, oncology pharmacist Katie Sias was preparing for her next patient when a physician came into her office, placed a full sealed bottle of oral cancer medication on her desk, and said, "This is a Honda Civic." Katie recalls this as the pivotal moment when she knew that she needed to do something different, and she discovered the CDR legislation. She registered to implement the program at her site for her patients, and the rest is really history. Soon after, 2 additional cancer care sites in Michigan launched CDR programs for their patients, and shortly after that, YesRx was founded to provide the infrastructure that was really necessary to scale the CDR programming that could reach and serve patients and communities across Michigan. You can go to the next slide, Ryan. So just over 2 years ago, we created the YesRx Network. It's an interconnected community of cancer care sites working together to increase cancer medication and eliminate cancer medication waste. And we launched with our 9 founding partner sites, Katie's site being one of those. And aligning with our mission to reach vulnerable and underserved patients, we created the network infrastructure so that sites of all sizes and in all locations can access CDR resources for their patients. YesRx directly serves the care teams with the level of support that they need in order for them to care for their patients. And YesRx provides all of those services at no cost to care teams or patients. And today you can see that map has populated and we have over 105 partner sites across the state. So the yellow circles are our partner sites and the blue squares that you see lit up are the counties that we are able to serve, and the counties that we're expanding into are those light shaded blue. You can turn or flip to the next slide for me. So pharmacists, physicians, nurses, financial navigators, social workers, all contact YesRx when their patient encounters a barrier to access. And we work with our pharmacy partners to locate the medication that's needed. And then we direct the prescription to the pharmacy and we ship between a 30 and 60-day supply of medication to the clinic for the care team to provide to their patient at no cost. This bridge, as you all know, gives the care team the time they need to secure longer-term support for their patient. Our partners share great joy with being able to provide a solution quickly to their patient, especially in these times of great distress. You can go to the next slide. So YesRx manages the statewide inventory. We work with several pharmacy partners who store CDR medication at their sites. These partners also dispense CDR medication to patients across Michigan. In our state, CDR medication can be provided to a patient who is a Michigan resident with a cancer diagnosis. It's really that simple. The need and demand for CDR programming is dramatically increasing since our formation, as you can see. We've gone from 20 prescriptions being filled for patients each month to 67. And YesRx receives donated medication from our partner sites and also directly from patients and families. And on average, each month, we're receiving around $2 million in donated medication. That's cancer medication, and it's also supportive cancer medications. We make it really easy for anyone to donate. We provide prepaid shipping labels and/or we provide conveniently located drop-off sites. We also receive donations from other states that don't have an operating CDR program, and they're grateful to know that their donations are reaching patients in Michigan. Eligible donations for our CDR program must be sealed in the original manufacturer packaging with at least 6 months until expiration, and they undergo a pharmacist's full inspection before they are accepted into the CDR inventory. You can go to our last slide, Ryan. So in 2 years, we have achieved our proof of concept for CDR programming that positively impacts cancer care access. We've received over $29 million worth of donated medication. That's, again, cancer meds and supportive meds. And we have been able to provide over $18.5 million in medication to patients in Michigan at no cost. And that's over 100,000 viable pills that have been prevented from waste. Most importantly, these outcomes have demonstrated a sustainable model that can support all clinicians, from tribal health clinics to large health systems, in their care of patients with cancer. Thanks, Ryan.
Okay. Thank you. And it sounds like that's some tremendous impact that you're having. I think words can't even describe how I feel about that, because unused medication that is it's a problem. I mean, yeah, we had a similar situation as the patient that you described, and I think every pharmacist that works in oncology has probably heard of a similar situation. So. All right, so next we have John Michael Rossman that's going to be presenting what SafeNet RX is.
Great. Thank you, Ryan, and thank you, HOPA, for making this opportunity possible this afternoon. So my name is John Michael Roseman. I'm the CEO of SafeNetRx, and we'll go ahead and jump to the next slide, please. So we are a 501c3. We've been working in the drug donation space for quite a while. We're going on 18 years now. So we first launched our statewide drug donation program in 2007, and it was the first statewide repository in the country. Some other notable developments in 2016, we launched our cancer drug donation program, and you can see a little cancer box there. And that's actually a donation box that is placed inside cancer centers. So when patients or providers have unused medicine, if it meets those donation requirements, they can fill out a little form and then just drop the medication into the box, and then that gets shipped to SafeNetRx when that box is full. In 2018, we launched a charitable pharmacy in Iowa, and then in 2025, we launched our first multi-state drug donation program where two state health departments in Iowa and Nebraska came together to form one larger comprehensive drug donation program. So I'll talk a little more about what our model looks like, and we'll go ahead and go to the next slide. So our model is a little different. We operate what's called a centralized drug donation repository. So we collect unused medications from all 50 states, and we've got about 250 clinics and pharmacies that donate medicine. This medicine is all sent to our distribution facility in Des Moines, and then we have staff and volunteers that log these donations into our inventory. We do run our drugs through an inspection process. So every unit of medicine is going to be inspected by a licensed pharmacist. And then we distribute this medicine, and it's not only prescription drugs, it would also be over-the-counter items and medical supplies as well. And we provide this donated medicine and medical supplies at no cost to clinics and pharmacies that are part of our network. So we actually contract with state health departments to operate the drug repository on behalf of the state. So the medicine comes to SafeNetRx, and then we provide that to primarily safety net providers. So that would include free clinics, federally qualified health centers, rural health clinics, critical access hospitals, behavioral health providers. It's any clinic or pharmacy that is providing care to an underserved patient. So for our services, that means that the individual is up to 200% of the federal poverty level, and then either uninsured or underinsured for that prescribed prescription. So if that individual meets those requirements, then their clinic or pharmacy can access donated medicine at no cost. So there's no cost to the clinic or pharmacy and no cost to the patient. And we've got about 200 clinics and pharmacies that are part of our distribution network. And then over the course of the years, we've now provided donated medicine to over 160,000 patients and collected 155 million in donated medicine. And then in terms of actual tons of medicine, it's over 800 tons that have been either redirected for redistribution or destroyed in an environmentally safe disposal system. Thank you very much.
Okay, fantastic work. Now over to George Wang and tell us about Serum.
Great. Thank you, HOPA, especially Ellie and Nicole for making this happen, and Ryan for moderating. Thank you for giving us the opportunity to participate in this great discussion today. Really glad to be part of this panel with you all. Just like these amazing other programs, just makes me smile to hear about all the work that's being done in this space. So I'm George, one of the co-founders of a nonprofit called Serum. Our mission is to find surplus medicine in the drug supply chain here in the US that's going unused, and then safely and efficiently get it to patients in need. We do this by helping individuals and organizations donate their surplus medicine, and we help match that surplus with a network of community partners like charitable pharmacies and free clinics. We've been doing this work now for about the last 15 years and super proud of what we've done so far. Ryan, you can go to the next slide here. As an organization, we've been able to distribute over $300 million worth of medicine to about 750,000 patients. Now, this is through our regular prescription medicine program, but there's so much more potential for this kind of impact to be had in the oncology medicine space. That's a lot of Honda Civics in my mind. Siobhan, I really like that analogy. And the folks at YesRx, SafeNetRx, and OSU are doing really incredible work in this space. And I honestly believe they're the pioneers and the leaders. Next slide. Their work with and as local repositories and cancer center repositories are honestly, I think, the gold standard. And I believe that this kind of work should be done in every community all over the country. Unfortunately, sometimes when we have spoken to folks, and they feel like they're stuck in various ways, whether it's capacity or administrative burdens, or maybe just limited resources in general. And so one option that at Serum we want to provide and help people do is provide an option for folks who want to be involved, but aren't quite ready to do the whole thing all at once. And so our goal is to make it easy for folks in that situation to help patients donate their medicine. And we can help you all do that with a low lift, but we still think high impact program. So our goal is to have everyone be able to participate in medicine donation, even as an individual pharmacist. So what does that mean? This kind of low lift, high impact program, simple and straightforward for pharmacists, oncology centers, or other organizations. We essentially at Serum send materials like pre-addressed, prepaid for mailers so that staff can hand patients the tools they need to donate. So then patients and family members simply put the meds in, sign a form, and that's pretty much it. We then can regularly refill the materials as these institutions and pharmacists need more, and then we'll also send feedback about the impact back to these organizations. Go to the last slide here. In just over 1 year of this type of work we've been doing at Serum, we've partnered with over 170 organizations. We call them referral partners, focusing specifically on oncology medicine. To date, it's been about $50 million worth of medicine that's been donated from over 40 states. And, you know, the impact is real, from health systems costs being reduced, obviously, to the impact of the patients and the families that can now access medicine that they couldn't before. But also, I'll mention it's to the families and the patients that make the donations. This is something that we didn't realize until we started doing this work. The families and the patients who donate often share overwhelming gratitude and empathy to be able to give new life to the medicine they don't need anymore. So overall, we hope that more institutions and pharmacists will join in doing this work. And if you're interested, we'd love to talk. Thanks, Ryan.
Thanks, George. And you know, I have a personal experience with a patient of mine that went off her therapy, and she's George hit the nail on the head. Like, she felt like this was a sort of like a her duty to donate her medication. So it's great. You know, what the group is doing. Okay. Last but not least, we'll hear from Dr. Kennedy Shaw at Ohio State.
Thanks so much for having me. I apologize in advance. I'm fighting a little bit of a cold, so I'll do my best. I was really excited to share with you our journey opening a single institution health system-based repository program where I would say 99% of our donations come from our own patients and are redistributed to our own patients. Like many programs, our repository at the James started when some of our HEMOC clinical pharmacists noted that there were a lot of patients and caregivers coming into clinic that had a surplus of medication. And in that same day, they would have another patient that came in who had a need for the exact same medication that someone had a surplus of. And so we felt like there was an opportunity there for us as a health system to be that intermediary between the patients. Next slide. So as the laws were updated in Ohio, we really felt like we had a few goals. We saw an opportunity to increase adherence, to prevent unused medication waste, to decrease healthcare costs, and to really allow our patients to care for one another during what is oftentimes described as one of the most challenging times in their lives. And so chronologically, our journey in 2019, we had some advocacy to the Ohio legislature. In 2019, our Ohio Revised Code was updated to allow oral oncology drug dispenses, including those that were in unsealed packaging, which really opened us up to do a lot more for our patients. In January 2020, we opened Ohio's first oral oncology drug repository, and the next month we had our first dispense. Then in January 2023, we really built on the success that we'd had in the oncology area and advocated to the Ohio legislature to expand to non-oncology medications, including some supportive care for our oncology patients, which led to, in March 2023, an update to the Ohio Revised Code, which we're really excited about. Next slide. I get a lot of questions about our exact workflow, and I'm not going to go through it line by line, but wanted you all to be aware that there really are a lot of people involved in this. But the backbone of our program are our clinical oncology pharmacists who are in the clinic. They're educating patients when they start their medication to say, hey, this repository is an option for you. They're collecting them, and then they're sending them to our specialty retail pharmacy for redistribution. They also play a significant role in identifying patients who may have a financial need and need an oral repository dispense. And then on the specialty pharmacy side, we treat it as though it were a commercial product. So it's going through all the same inventory management, safety checks, drug dispensing as any other specialty medication would. And if you're building out your own infrastructure, I think that's really key. You want this to operate the same as you would any other specialty pharmacy medication with all the clinical checks and balances in place. Next slide. A little bit of data for you. So we've dispensed a little under 8,000 tablets and capsules in fiscal year 25. We have partnered with Serum, so many thanks to George and his team. There are medications that we end up with a surplus of that we don't have a patient population that needs it. And so instead of letting that medication sit on the shelf and expire, Serum was gracious enough to work with us to allow these large dispenses that we're sending to Serum when there are medications that we don't have a patient need for. So thank you again, George. And then on average, now that we've built up our program, we're doing around $2 million in dispenses, again, for our own patients at Ohio State. The thing I think that this slide doesn't touch on, that George touched a bit on, is the unexpected result from not just the patients, but their caregivers as well. I think about a clinical pharmacist who worked in bone marrow transplant who shared with me the story of a patient's spouse who came in following the passing of her husband. And they'd been on a long journey together through a transplant, through post-transplant care. And she came in with an entire bag of medications and sat for over an hour with our clinical pharmacist and the nurse and went drug by drug to see what could be used for another patient. And so it reminds me how grateful I am to work in the cancer community who really cares for one another. And the pharmacist had tears in her eyes as she shared this story with me because she saw the impact that it was making, not just on the patients that receive the medications, but those that donate and their caregivers as well. So I'm always happy to teach other people about building a repository program. It's certainly been a great service to our patients. And thank you again to HOPA for having us so that others can learn to do the same.
Okay. Well, thank you to the group for it's clear, like these, like the individuals that are online. It's strange to think that we live in the same world. like the group of individuals that are attending, like they exist in the same world as these other individuals on the line that are doing this incredible work. So I can't thank you enough. So I will unshare my slides. Oh, sorry. Stop share. And we will move on to the panel question discussions. And we'll start with SafeNetRx. And this question asks, how can pharmacists determine what their state currently, or whether or not their state currently allows drug regulatory programs?
Sure. Well, there's a couple of resources to share here. First would be the National Conference of State Legislatures, and they maintain a database of the state-by-state legislation that has been passed in each state, and it provides some nice information on where states are in implementing a drug donation repository. For more specific information, I think it's best to consult your state board of pharmacy. There are no federal regulations around drug donation, so each state is regulated by its state board of pharmacy. So for the most comprehensive list of information, I would just simply refer to your state board of pharmacy to determine where your state is in terms of enabling drug donation legislation. And if there is legislation that's been passed, then specifically you can get details on what is allowed or prohibited in your state to access donated medicine.
Super helpful. This question is for Serum. If a state does not yet allow repository programs, what steps can pharmacists take to begin that conversation with local lawmakers?
Yeah, great question. I would say there's a couple of steps to take. First, it's trying to find some local representative or legislator that might be interested in this work. And so you can start with perhaps your own local state senator or state representative. And they, I mean, that's part of their job is to like take calls from constituents. And so they'll usually take a call and have a conversation with you. You may not find exact alignment or interest with your exact representative. In that case, I would look slightly outside of that scope. If there's a pharmacist in the state legislature, that would be a good advocate. Another healthcare practitioner, like a physician or a nurse, or someone on like typically there's like a health committee at the state representative level, and those individuals can be helpful too. And you want to obviously talk with the representative or senator. Ideally, that would be great, and sell them on an idea, have a conversation. Probably just as good as a legislative director or staffer, and basically tell them about the idea, what other states have been doing. I would definitely be clear that these efforts across the country have been bipartisan and honestly have no opposition. And so these are one of the few things that kind of from a legislative side, it feels like these days it's a no-brainer, and it really goes across both aisles. Once you find interest, then there's another couple steps. Obviously, there's some language that needs to be provided at some point, or you have to work on the actual language with the drafters. Then there's a further step of having like one-pagers ready, testimonies at committee hearings, etc. And those are all things that I know most of the people on this call have probably been involved in all. John definitely has, and Julie, and I bet Siobhan also has been involved in like kind of the state process to either do regulations or statutory changes. And Serum has done this across many states at this point. So I think anyone on this call would be happy to help you with any of these details. We have a team of folks that work at Serum, that our whole like existence, at least for that team, is to make sure to further good policy that's happening around the country. So we're always happy to provide model legislation or help in any way to have a conversation with your local lawmakers.
Cool. This question is for Siobhan. What advice would you offer for other institutions or states considering launching a repository program? Like any inside advice for that venture?
Sure thing. we're happy to offer what we've learned from our approach and from the activities that we still do regularly. For example, for our model, a statewide model where we're really trying to serve all residents, evaluating that upfront, the shared interests across your state, right? So we focus a great deal of effort in forming groups that interface with the oncology care teams so that we can create that ecosystem where extended support can exist and everyone is aware of the resources. We also focus on the feasibility of the CDR program, reaching the patients who are most at risk. At the heart of our model is decreasing the further fragmentation of oncology care. And so this allows those care teams to deliver really good news to their patients quickly in a time where they're not delivering good news, right? And the result is a significant increase in clinical and patient satisfaction and also engagement in the program. We integrated the patient voice very early on prior to our launch, and we continually do it. And we do this via focus groups and patient advocacy organizations. And as George was commenting on, how you can go about this, really engaging with your state professional societies is critical. We have a phenomenal group, the Michigan Society of Hematology Oncology. They're a mission-aligned partner, right? They are well-versed in advocacy. They were part of oral parity. They know the ins and outs of bringing this kind of work forward in a state. Securing funding to support your infrastructure or the model that you're going after, right? And the administration of the programming. You really need that for stability and longevity. And really, really critical is finding mission-aligned partners, right? On the ground, caring for the patients, but also in that greater cancer community. It makes this work the most impactful because of that ecosystem approach, right? So those are some thoughts.
Thank you. I see the Q&A is buzzing. So this is going to be the last discussion question. It's for Julie. How have you ensured safety, quality, and tracking with your donation model?
Yeah, it's a great question. So we do require that a pharmacist inspect every donation. Oftentimes that is our clinical pharmacists who are on the front lines in the clinic receiving the medication directly from the patient. That includes looking for tampering, any signs of poor storage. Our patients also sign a form saying that they've cared for the medication, it's been stored appropriately, et cetera, at the point of donation. And then from a tracking standpoint, I mentioned earlier the importance of setting up your repository program as a true pharmacy. And so we have Epic as our EHR, and we use Willow Inventory, where we receive all of those medications into our inventory. Anyone at the medical center with pharmacy access can actually log in and see our inventory to track and see how many of a particular medication we have in stock and whether it may be an option for their patient.
Thank you. So now we'll move on to the Q&A, and I'll try and I'll pick these off one by one. Anyone feel free to chime in. I think George will have an answer to this one because well, maybe you can clarify. So can you provide any advice, guidance, experience with navigating drug donations in states where repository donations are limited to healthcare entities? Some states prohibit donations by individuals, patients, i.e. closed system. So can you speak to that?
Yeah, I'll briefly say, and other folks should jump into, but there are definitely a decent amount of variation between what each state drug donation law allows. And so some states do limit the types of medicine donors and what entities or whether or not individuals are allowed. And so in this instance, obviously, working with your lawmakers to make a change, because individual donations are now, I think, part of a lot of robust programs around the country. So I think it's a pretty easy pitch to make those types of edits. But before that might happen, it's partnering with an entity like ours or anyone on this panel, right, to offer a donation option for those individuals to donate to another program that does allow individuals to make donations. And so oftentimes folks want to donate as locally as possible, but at the end of the day are willing to make donations to out-of-state programs as long as, you know, that is a proper outlet to be able to like get the meds to somebody in need.
Okay. And this is, thank you, George. This is probably a simple one. I don't see a reason why this would be a yes, but are anybody with experience with dealing with pediatric patients, and are pediatric patients eligible for these programs? Or are there any age restrictions that the group knows about?
I can offer that in Michigan, we are serving pediatric patients, so we don't have an age restriction. Yep.
Okay. And anybody have experience with drugs from federal entities, just such as the VA? Like, is there any special precautions or restrictions that are placed on patients that get their care through federal entities?
I can jump in and just say that donations from federal entities have happened. It's a little bit, I'll say, a little bit trickier to actually get the federal entity itself to make donations. But from medicine that might have gotten into an individual's hand and then subsequently not been needed and then donated, that has happened.
All right, this is a good question that we are struggling with ourselves, and I see a few people asking about it. So I just want to make sure that well, this may be more for Julie, but how do you, obviously this takes a lot of work. I mean, you have like a really comprehensive working and setup. And how do you justify to the powers that be your staff's time and to contribute towards the repository? Because I assume that you need institutional buy-in for additional staff to process the additional inventory and also on the distribution side. And we know that you cannot bill a patient for a donated drug. So like how is this justified in terms of the lack of revenue, if that's the right way to put it?
Yeah, it's an excellent question. It does not generate revenue. It is 100% an altruistic journey on our part. I would say that we've done our best to make the process as efficient as possible. I will say that our clinical pharmacist really taking the lead on that drug inspection piece in the clinic. It's pretty low volume for them. It's, you know, an occasional donation that they're reviewing instead of needing a centralized resource to do all of that review. So that's one change that we made to make the resource need a little bit easier. We also leverage our learners. So we have interns that help with the program. We have pharmacy practice administration residents that help with the program. At the end of the day, there is some staff component. And so we try to put that in the bucket of the altruistic care that we provide. That's part of our mission as an academic medical center. And quite frankly, otherwise, we would be spending probably more time and energy trying to find an alternative therapy for a patient that needs a medication, because if they can't get this drug from the repository, chances are we're going to be spending additional staff time looking for an alternative. They might qualify for free drug that we would be paying for anyway as an organization, or just physician, pharmacist, staff time trying to find those alternatives. So I'm sure those of you that work in oncology know that we spend a lot of time on medication access. And so this actually makes our lives a lot easier when we have this option for patients.
Thank you. And I'm assuming this question asks about liability I'm assuming most of your programs, there's a consent signed with the patient receiving the donated medication such that they know where it's coming from. Is that correct? I see some head nod. Yeah.
Yes, and at our institution, we actually have the physicians have that conversation with the patient up front to say, hey, we have this repository program if you're interested, and we have them document that in the electronic medical record, so it's clear when the patient comes to the pharmacy that they know they're receiving repository supply. And then, of course, the patient signs a form.
This is a curious question. How often do medications expire in your supply? Like Julie, you mentioned that you've partnered with George's group for unused medications that you can't find a patient for. But how often do they expire, and what do you do with them after?
I'm happy to jump in on this.
Sure.
There's an abundance of medication that does expire. I mean, we all do our best to make sure that there's a patient that's able to utilize it. But when you're dealing with donated inventory, in order to ensure that clinics really have access to as much of the medication as they can, you have to open up your inventory and show them absolutely everything that you have currently. So there is some expiration. I mean, it's just part of your daily operations is going through your inventory on a monthly basis and pulling out dates. You know, at SafeNetRx, I think about 70% of our medication actually ends up in the hands of someone that can use it. But with this type of program, there is waste, and how you manage that waste is important. And I think all of our programs do a good job to ensure that medication is appropriately disposed of in an environmentally safe manner. So it's a great question.
I'd say one strategy we've used to decrease waste is being a little bit more liberal in our definition of a financial need. Recognizing that we had medication sitting on the shelf with the potential to expire, and so not limiting ourselves to very strict guidelines for which patients would qualify, understanding that there could be patients that could benefit from this that may not meet our previous financial guidelines. So that's one strategy we've taken to decrease that expiration problem.
Yeah, I echo that, Julie. And I saw one of the questions about what if you need it beyond 30 days? Are you only giving out 30-day? And when we have excess of inventory, we by all means will meet the need of the patient at that time. So sometimes it's 60, sometimes it's 90. We actually have a patient we've been able to provide drug to for over a year now. But one avenue to look into are research labs that can use FDA approved drugs in their research. And that's an avenue that YesRx uses with mostly our ineligible medications, because our in and out of our inventory is so high. We don't encounter a lot of expiring meds, but we do accept but not into the repository. We help people out when they are donating drugs that are ineligible. So a drug that's opened, a drug that is already expired before they try and donate it. And those drugs we can provide to a research partner who looks at alternative uses for FDA drugs.
Thank you. This question asks, are there any restrictions based off of class of drug donated? And I think, it gets into, are we dealing with oral anti-cancer medications or injectable medications? From my understanding, there's nothing restricting about an injectable medication if it's not expired to be donated. Granted, it doesn't. My perspective is on this is it doesn't happen that often. But is there any restrictions of like this class of meds is not, kosher to donate or
Controlled substances.
okay?
Yep, are not eligible for donation in Michigan.
I think it varies by state, what's eligible and what's not eligible. Like I mentioned before, we started with oncology and then lobbied to increase what was eligible. One challenge that we've continued to have specific to the oncology space that I hear other states may have, which George may be able to comment more from a global standpoint, is medications that have a REMS requirement. There was a push from pharma to exclude medications that have a REMS requirement. So we've been unsuccessful in lobbying to change the laws in Ohio related to that.
Yeah, I'll say REMS is the one area which it gets a little bit tricky, even more specific state by state. And again, we have thoughts about that, and we have language that has been adopted by many states for how to kind of safely increase the possibilities of what can be donated.
Yeah, I have a lot of thoughts on that, but I will save them. This question is a curious one. Do you only dispense oncology medications for FDA approved indications, or what if it's an off-label indication, or you can't, like if it's this in-between period where a patient is in need, a doc wants to use a drug that's for an off-label, and you are not able to confirm whether or not they're going to get the next supply, but you have a repository supply in your balance. Like, what is the guidance, or what do you do in that situation?
I can take a run at this.
Yeah.
So sorry, let me gather my thoughts around this again. Start with the question again, and I'll give you my response on it.
So what is your the question asked about like only FDA labeled indications, and
Yeah, okay, great.
But I think there's this insecurity of whether or not the insurance will pay for it, or whether you're going to get like a free drug program to sell the patient well. So in these situations where there's anxiety about the ability for the patient to continue on that med for complicated reasons that maybe have to do with being on or off label. What do you do in those situations? Like, what's the guidance?
So I think it depends on how your entity is licensed in your state. So for example, SafeNetRx is licensed as a wholesale distributor. So we are simply filling a wholesale order, and we have no input on how that medication is actually dispensed to the patient. So it's purely a wholesale transaction. If your model is a pharmacy, I mean, that's obviously a different setting, but I think the first question would come down to, how are you licensed in your state?
Yeah, I can comment more from someone who looks at the patient holistically. This is something that we've had a lot of discussion and debate about. We feel very strongly that we do not want to start a patient on a chemo regimen that we do not have a plan for continuation. So we actually don't approach our repository as a one-time dose. We really want to make sure that we either have repository supply for continuation of therapy, or that we have an insurance approval. Oftentimes what we see though, for kind of the most common use for a 30-day supply would be, we know the drug is approved through the medication assistance program, but there's a shipping delay, or we're waiting on logistical concerns. And so this is a way for us to start them faster. The other common scenario that we see is insurance change. So the patients were previously stable on an oral chemotherapy. Now they have a new insurance. Now there's a significant delay in getting that prior authorization completed with the new insurance company. And from an off-label standpoint, we do a tremendous amount of off-label. That does not bother us, but if you're trying to do it off-label because you don't have insurance approval, I would say apply all my previous comments about making sure you have a plan for continuation of therapy.
Thank you. There's a question in here about Drug Supply Chain and Security Act of 2013, and how if these practices, if these processes are I'm assuming abiding by that statute.
I can jump in. John and I have had many conversations about this. There are carve-outs for these types of programs as the bottom line, and we're happy to share with you documentation about what that looks like. But basically for charitable organizations and repository programs, like all the ones that we're a part of, carve-outs do exist. So it's not been an issue.
Okay. Okay. Well, Thank you, George, Siobhan, John Michael, and Julie, for your sharing your experiences and expertise with us today. Thank you for all of our attendees that are joining us online. Thank you to HOPA and the HOPA staff. This would not be possible without your efforts. And so, you know, the HOPA staff, everybody knows the HOPA staff are incredible. As you leave today's session, I encourage you to consider how you can take part in this movement, whether through advocacy or partnerships, or integrating repositories into your own practice. Every effort to help this expanding, you know, group of individuals and can make a positive difference in terms of reducing waste and ultimately improving patient care. So once we close the webinar, a short post-event survey should pop up on your screen. We greatly appreciate your feedback as it helps improve future programs and continuing offer relevant, impactful discussion. This is why this is happening here today. So, you know, we very much want to hear from the members of HOPA, what you know, what you want to hear in these webinars. If you'd like to revisit any of the information, a recording of this webinar will be made available in the next couple of weeks and communicated to the members. On behalf of HOPA, thank you for being here today. Thank you to our panelists, and we look forward to seeing you at future programs. So thank you very much, and have a good rest of the day.